So, good afternoon, everybody. We are right in time to start. Everybody is in the room, and we are going to have some time together. We have 1 hour to redefine the future of transcatheter aortic valve replacement. And I'm here together with my spokesperson, Dr. Pilar Jiménez Quevedo from Spain. We have two big experts, one interventional cardiologist, one surgeon, and sometimes also opposite, Jörg Kempfert and somebody who has a future, I think is a rising star, Martin Leon. I know him. I think in the future there is some opportunity. We have a great chat master, so if you want to interact, you can interact both speaking with us or by our app, which is Dr. Van Bailey from Netherlands. We have Iris. Iris is Italian. Iris, welcome. Who's going to make some drawings. So if you say something funny, she will probably make a drawing. So if you think about it. So interact with us, you get the picture. And we have a number of speakers I will introduce time by time, but from different sides. And again, this is meant to be a kind of a brainstorming session, something like they call it jamboree. I learned today from Bernard Prendergast. Who knows what is jamboree? Something like that. Something what happens today. I don't know what that means, but it's a nice name. So, okay. So let's start with the interview to the experts, and the topic and the objective is what is the ideal platform for the future? That platform for aortic valve replacement that is going to become the best option for the largest majority of our patients, and feel free to give us also directions. So, Pilar, is your time. I will say here, I will take notes. I will be like taking notes.
You already say the question. So let's start with the implant phase and then with lifetime management. So what do you think is going to be one of the features for the future TAVI platform?
So what was the name again? Jamborino? Okay, I still don't know
Jamboree.
what this is, but I can remember when I was a kid, there was the Christmas wish list. So let's assume I had a wish for Christmas for a new TAVI valve. I would like to have something that is not going to use any PVL. Coming from the surgical side, for me, this is still a major one.
Okay. No PVL, so you don't like PVL. Good.
No, surgeons hate PVL. I learned this a long time ago. So we started thinking about transcatheter valves when I worked with Alain Cribier about 25 years ago. We had an aspirational wish list. And I'll tell you, 25 years later, we still haven't gotten there yet. So to me, there is no perfect valve yet. But we had a good list of things that we liked. What I learned, however, was the initial list changed over time. And one of the things that became, to me, very important was what we call ease of use or generalizability, so that the system can be used by physicians who have varying skill sets with good results. And to me, that's one of the most important properties of a successful TAVI system and why it's grown so much. But I would add, because I agree with Jörg, that the two things I would not compromise is PVL. I don't know if we can completely eliminate it, but it cannot be above mild, and I would argue that the mild number needs to come closer to trace, and AV conduction. I think you need to have single-digit pacemakers. Those are some of the initial fundamental features, and I'm sure we'll talk about some others too.
I mean, these are typical bullet points that we had on the old wish list that are still relevant. And we have also discovered, I guess, some new ones that from a surgical perspective, for me, wasn't so important at first glance, which is coronary access. This is, I think, something that in the first phase of TAVI, it wasn't such a huge issue. Not only for coronary access in case of urgent PCI, this is a very obvious one, but most importantly, now that we are going to the younger patient cohort, we also durability hopefully is good. We all know that a significant portion of these patients will get have to get a second valve. And this is why then this is a, I don't know how we call this. This is not direct coronary access itself, but it's more revalvability or something like that, if this is an expression. You can invent one, Francesco.
You know, it's funny, in the beginning, we used to use this phrase, commissural alignment. We didn't even quite know what it was, to be honest, and it was pretty much irrelevant in the early days, where all you could do was treat these high-risk patients and hopefully get out of the lab safely with a reasonable result. Now, suddenly, everybody is obsessed with coronary access and commissural alignment. So I think there's something to this, and I think it's an important feature of a modern TAVI. If you want to be competitive, you want to have access to the coronaries. You're treating people younger, they're going to have STEMIs, they're going to have diffuse coronary disease. You must have relatively unimpeded access to the coronary. So that's another feature that I think is pretty important.
Yeah, it's interesting because, you know, I think the very first the objection from the surgical community, even from me, I mean, which I've been one of the first believing, but I thought coronary access, coronary obstruction would be the problem. Okay, you remember that, at very, very beginning, and Cribier convinced us with that single picture showing us that the coronary level was above the leaflets. But now it's coming back, and it's a matter of coronary access, but also you mentioned the possibility to do multiple valve-in-valves. I mean, when we think about a lifetime management, probably also, I don't know how to call it. My name is, I like revalvability. Anyone has a different name for? Retreatability. No, treatability is one time. Multiple treatability. Find a name for your next database. Let's call it Vivid 2. Redoability.
So what did you put there? Coronary access, or how did you name it?
I think coronary access is 1.0, even for the first implant.
This is
the problem is
stuff,
what you when you do 2, 3 times, 4 times. I mean,
revalvability.
Revalvability. Revalvability. You like revalvability? Who likes revalvability?
Yeah, but that's many things.
It's gonna be in the written in the textbook afterwards. And then don't complain, eh? I'm writing the textbook now. Eh? Revalvability. Revalve.
But this is something that is
ability.
This is the end effect, right? But I mean, the most specific parts is, I guess, if we break that down to acute coronary access, we know what this is, but it's more the combination of the low neoskirt and the option to go for anatomical alignment. And these two factors are going to impact the revalvability, which is going to be in the textbook.
Yeah, but I also think what will impact it is the hemodynamics. So, I mean, you can have coronary access, but unless you achieve good enough hemodynamics where you can safely put another valve in with expected reasonable durability, then you've lost it. So hemodynamics now has been certainly raised as an important feature. You know, and there are a lot of reasons why that's so. I'm not sure, you know, and you can argue between, you know, echoes or doing invasive gradients. I don't really care so much, but the issue of getting consistent good hemodynamics, I think, is important in terms of, you know, the long-term sustainability of the platform.
So hemodynamics is obviously. So you are unhappy with the current hemodynamics, or what is the background?
For valve-in-valve, I'm not happy. No.
Okay.
I mean, why are we cracking valves? I mean, you know, I think that in small annuluses for some systems, and for valve-in-valve, I think the hemodynamics are acceptable, but barely. And they should be better.
So we touched about the new textbook term, revalvability. So the question is, why would you want to revalve only if the durability is over? Let's put it that way. So durability definitely is an acute or midterm thing that is important. I know it's hard to assess. We don't have the data yet. But on the wish list, it's Christmas time. So let's put it, huh?
Marlene, is there any question from the chat? Nobody wants to have more than that?
No, not yet.
No. Low price? I was thinking about low price. So durability, dura mater, You see, the risk here is that you don't know how to write it in English, and everybody sees that you are an idiot. So I hope it's okay. Good. So
let me ask you, we talk about the location of the valve. Intraannular, periannular, supraannular. Is that a characteristic that you would want or not want? Do you care?
well, if I think about my current practice, I like to have intra-supraannular depending on the situation, obviously. It's not bad to have a supraannular design in patients where I need to go for valve-in-valve. On the other hand, having an intraannular obviously has a more long-term perspective of access to coronaries and revalvability and so on. So this is to go back to your first statement, I think there is not an ideal prosthesis. I think the only ideal valve has been made by the guy upstairs. And unfortunately, it didn't give us the recipe. But we need to find the right compromise. And the question would be even whether one valve fits all, or we need to have multiple solutions to tackle the different things. And we are collecting many different things. Is there anyone who wants to suggest? I tell you some secrets, guys. You need to know. In the back, we have not only the Abbott engineers, but there are also other companies' engineers. They are taking notes. So you can ask now, whatever you want. For instance, okay. What do you want?
Low profile,
Low
bleeding and vascular complications.
So how
small.
low would you like? This is very important. Is 18 good enough? 16, 14? What would you like?
Well, if it is...
You want transradial?
Somebody's saying radial, but being a little bit more realistic,
What would you like?
8 French, 10 French,
Interesting. There is a
maybe 10 French.
system being developed that is 10 French, but I think it's not easily achievable in the current valve designs to get down that low. And but that's an interesting point. I would argue there are a lot of complex anatomies, and the one that if you talk about a valve for life, you have to talk about bicuspids. So you've got to have a system that really is going to be effective in bicuspids, that have a lot of eccentric and bulky calcium that extends up into the leaflets. And you also have to deal with situations like extreme horizontal aortas, unusual anatomies, so the system has to be very deliverable. Now that's part of ease of use, but that also is another characteristic.
So when we talk about versatility, it starts to be a bit complicated wish list. There is one wish which is a bit,
I thought you would draw a funny picture, though.
She's doing that. She's making fun of me, first of all. She made me too fat. Look at me. She made you too young. And York before having the new look. You don't have this anymore. No. You need to update. I think till now the only one who's getting pretty good is Pilar. I like you. I like you very much. But
Thank you very much.
But you don't have the glasses today. She's much more beautiful without glasses. Take the glasses out, please. I agree with you. Better stop here. You want a valve with complications, otherwise we don't have ICI complications. We want complications, correct? Yeah, please make valves with complications, otherwise we cannot do the complication meeting. Okay, no other wishes here? It looks like
There's one suggestion from the audience that we need a valve that can also treat AR.
AR, wow. Why we forgot AR? So, should be versatility or something, another category? That is an important point.
That's an interesting question, right? Whether or not do you want to really wish one device that can cater for all needs, or is it more realistic, or does it have more sense to break it down to different engineering concepts? This is, I guess, the question. If you want to have one size, one valve fits all needs, or do you want to prefer have a selection of devices that are specifically designed for one or the other aspect of these wish lists?
It's a good point. I forgot when you were talking about the low profile. I remember, I don't know if you remember, Marty, at the mitral valve meeting, we made a kind of exercise of being very provocative, and we managed to make a startup developing a valve with wireless implantation that you just build it inside the body. That would be nice. Something like you just some microbots that come in the vein and boom, boom, boom. Huh? Nice, huh? Can be done.
I think that if you try to do everything in one device, then you start making too many compromises. So I really think the design is different enough for AR that I would probably put that aside, because I just think it's a different application.
So I think it's a very good point. Probably we have been doing a little bit too much of trying to fit our devices in our patients and not the opposite. I think it makes a lot of sense. You know, what I would suggest now, we have some beautiful cases to support our discussion and see where we stand. Obviously this is a sponsor session. We will see some off-label indications, so I will take full responsibility, so don't worry about some more than 2 leaflets, less than 3 leaflets, things like that. But we will check these cases, and we can, if you want, interact and say, okay, I'm convinced that we achieved, I don't know, hemodynamics, whatever, with these cases. So the first case is from Tiffany Patterson, who shows us a case which is called TAVI through a tunnel. And I take responsibility as well of the titles. We have been trying to make the funny titles. I don't know if it is a funny case. Let's see.
Okay, so my name's Tiffany Patterson. I'm from St Thomas's in London. I'm going to show you a case.
Wait a second, because we don't have the case now showed there. Maybe we need some help from... Okay, thank you.
Fantastic. So we're relatively new adopters of the platform, the FlexNav Navitor device, but actually it's come in very handy, and we've noticed there's been a lot of gaps in our practice that have been filled by this specific device, so it's been very useful. So this is a case of an 88-year-old gentleman with low flow, low gradient severe aortic stenosis who'd been under surveillance for a while, but actually started developing progressive symptoms and was NYHA class 3. So it's one of our sort of typical high-risk patients. The patient had lung disease, emphysema, history of asbestos exposure in pleural parks, reduced FEV1, reduced transfer capacity. So, as is often the case, coexisting vascular disease with a previous EVAR performed in 2019 for bilateral common iliac aneurysm. So it's actually an EVAR with bilateral iliac extension and also a right-sided internal branch device, which just meant they stented into the internal iliac. So it was discussed at the heart team initially when I wasn't there, and they felt that this was probably a non-TF TAVI. So for consideration of transapical TAVI procedure and also to review the images to consider subclavian access. So if this is just playing through. You see it's playing a little bit quickly, but we've got the EVAR there and extensive stenting. And this would conventionally, and certainly historically, have been prohibitive for transfemoral access. So we considered all the options.
How recent was the stents in the EVAR?
Say that again, sorry.
How recently were they placed?
2019, so,
Okay, so 4 years.
What, 4 years, yeah, 3-4 years ago. So here's a zoom-in vessel reconstruction, just done on a simple PAC server, not done anything clever here. But just on the left-hand side, you can see the left-hand panel, you can see the extensive stenting that extends into the external iliacs, very close to the common femorals. The common femorals severely diseased. So there's lots of prohibitive factors here about this patient, and the vessel size goes down to 5.5 millimetres, but not your conventional 5.5. This is 5.5 with stents. The left side was worse. The right side was preferable on balance. So I had a chat with our vascular surgeons. So the annulus, looking at the aortic valve annulus just very quickly, this was certainly going to be, for us in our centre, a self-expanding device. There was heavy STJ calcification. The annulus size was reasonable, neither extreme, 415. Sinuses were slightly on the larger side. On balance, decided to go with a 27 Navitor. And the reasoning behind this was the deliverability. We found that increasingly, although I'd not done an EVAR before, an iliac stenting with this device, I'd found actually the deliverability was so smooth and easily done that we thought it'd be reasonable to try this and just have our vascular surgeons on board. And if we needed bailout, we needed bailout. And there was two issues. It was the CFA that was heavily calcified and diseased, but also the extensive stenting. So this is just for contralateral access. I'm showing you the images that I took at the time. So we start all cases with micropuncture, bilateral access because it was a self-expanding device. And you can see there's a lot of stent to negotiate. And on the right-hand side, I've just done a quick picture to show you what actually is happening here. So you've got the EVAR, then extending bilaterally into the iliacs, and then you've got another branch there. So I then jump to the valve procedure, and the valve itself was uncomplicated. This was a nice, straightforward procedure. And what's nice for us is that having not been a high-volume portico centre, when we moved to Navitor, actually, it was so easy to use that we were able to adopt it very quickly. So we've adopted it for subclavian and transfemoral access, and valve delivery we find very straightforward. So this is now the device coming out. So the reason I'm showing the device coming out is because some systems are reportedly 14 French, but they actually expand as they come out. And these stents tend to move. So the reason I was screening it out, and I screened it up, but that wasn't saved. The reason I was screening it out is because often these stents can move when there's friction, and often there can be friction after valve delivery. But these didn't move at all. They stayed intact. You know, there's also a risk of endoleak, hence the aortogram. But all of this was fine under the very close watchful eye of our vascular surgeons. So you can see this final check shot. There's a small leak. When I'm worried about vascular access, I often I tighten the ProGlide over an 8 French sheath, take a picture and see where I'm at. And I can see here there's a small leak. So I close with an angioseal. And just to be absolutely sure, so we didn't have to go back in, I punctured just beneath with a micropuncture kit and did a check shot, and everything looked fine. So actually, we got away with not doing subclavian or transapical, avoided general anaesthetic here. And for me, that's pretty dramatic. You're an 88-year-old patient who otherwise would have had to undergo a really heavy-going procedure and then have remained in hospital afterwards. So actually, this was a great solution for us.
Thank you, Tiffany. So. When you present this case, you want to convince us on which one of these features here? Maybe low profile or ease of use?
Yeah, well, I think that there's a lot. I think every case,
Deliverability, maybe?
Yeah, deliverability. So just for this specific case, it was deliverable.
Which is one of the typical advantage, I think, of this specifically of this platform.
But
Very well.
Every TAVI you do, you want it to meet all of these criteria. You know, you're thinking ahead, aren't you? You're thinking about, are they going to get a redo TAVI? Oh, this guy was 88, maybe not. But you know, you want all of these benefits.
I think I don't know who has experience of TAVI in a patient with a previous EVAR. I have. Also very bad experience. Who has a bad experience? I have. you know, the vascular surgeons have been almost killing me afterwards because because what happens is, you know, if you treat and the question from Martin Leon was very important. How old is the procedure? Because if you treat right after EVAR, the branches may be very movable.
I think this case shows the flexibility of the platform. So I think you can put something on easy to use.
The ease of use is, yeah?
I really think that. I would like to make a question. Do you change the secondary access to the radial? You always use the femoral?
I know, so from my perspective, it's if we need to cross over and do any sort of bailout strategies, it'd be very difficult here with the EVAR. It'd be probably be a surgical bailout, if anything, from the vascular team. But generally, I do use femoral. I know people can get large enough sheaths through the radial, but for me, it's a case of knowing the length of my vascular bailout kit and being able to cross over and doing something I'm familiar with. So if I needed to do a bailout procedure on that side, I'd get contralateral access. It's just what I'm more familiar with in terms of stenting the vessel.
Obviously, in EVAR, I think it's almost impossible to do crossovers.
No, it'll be surgical
Almost
bailout.
impossible.
Yeah.
It's not impossible. Nothing is impossible.
Yeah, in this case with iliac limbs, I think it would be, you know, essentially impossible to do a crossover.
Almost.
Yeah. Well, I mean,
Never say never.
you could always try anything. But so in this case, I'd be prepared actually to have secondary access from a radial with, you know, long wires and long equipment. Have it ready. We would probably, because these can be so tricky. But you know, each center is different. But we've got some people who are really strong endovascular people, and we would, you know, involve our endovascular specialists to, you know, discuss what the strategy would be in terms of equipment and what the bailout would be if we had a complication.
And don't forget, though, that, you know, it's quite a long way from the arm. And an 88-year-old will have a lot of tortuosity of the vessels.
It could be, yes.
So it's worth considering that as well.
No, you're right. I mean, it may not be the best approach, and you do need longer wires, and you have to be prepared if you're going to go, you know, radial to be able to bail out a femoral access site. So you've got to be ready.
I think very important just to inform your vascular surgeons, at least, you know, up front, because I did it afterwards. It was a disaster. So listen, I have a little problem on your page. You remember this page?
But also what we have to mention here, you used a nice trick of the micropuncture on the large access site, which is, I guess, underused sometimes because it gives you the extra option to have access and just for visualization. But also if you need to do stenting, also this access can be used.
Under. So. Yeah, we've had that a few. Well, we've been bailed out a lot by our vascular surgeons, so we've learned a lot of their techniques. So we picked them up along the way.
So thank you, Tiffany, for this case. I think...
Good case.
You know, so this is an example of a let's say compromise. This platform, the Navitor platform, is very little metal, so very flexible, very deliverable. You compromise maybe a little bit the radial force, so it's always a compromise. But that shows that versatility. What about the next case? We have a new case from Danny Dvir, who is going to speak not about valve-in-valve, not about basilica. It's a premiere. It's a premiere. So you know something else out of that?
Yeah, I hope.
Amazing. The most horizontal aorta you ever seen.
I have ever. Maybe you see. I don't know. Thank you very much for the opportunity to present here. So many good friends here that I see. We'll go forward. It's an 84-year-old lady with a severe AS, a severe symptomatic, nothing unique, except for extreme kyphoscoliosis. This is her aorta, which is tortuous, very tortuous. We'll focus on some of these parameters here. There are several tortuosity patterns here, both the distally and proximally. This is the injection through the leg. She is considered for TAVI. This is the left side, really like a roller coaster. And this is the aorta. This is the aortic root in 3-cusp view, LAO 42, caudal 27. A very abnormal angle, right? So it got like a 92 angle, Francesco.
It's nice. It's really flat.
Yeah. It's fun.
I like it.
It's interesting what nature created, right?
Flat.
And this is the right-left cusp overlap view, which is usually in RAO caudal. Here it's in LAO 34, caudal 48. And this is the delivery of the large sheath through the leg. You can understand that there are many levels of tortuosity in this case. And by the way, we use the left leg for the secondary arterial access, but maybe the radial was a good approach here, but I didn't. And this is the traversal of the aortic valve. Nothing unique, needed a long catheter, long AL, but nothing dramatic. I was so confused about how the relationship between the aortic valve and the LV looked like that I wanted to inject in the LV to understand where actually I need to position the stiff wire in the LV. Actually, the LV in RAO 30 looks normal, but look where the aortic valve pictal, like the aortic valve, the annulus, in relationship to the LV. It's so abnormal, right? Balloon valvuloplasty as usual over a Landerquist wire. And obviously, this is going as for ease of use for the Navitor platform that for sure, to me, this is the right device for that anatomy. Delivery through that crazy abdominal aorta, not a problem. Delivery through that hairpin aortic arch, not a problem at all. Delivering through the aortic valve, also not a problem. And here we do regular TAVI. It was not actually no need for reposition, no challenge in the case. This is how it looks in AP, by the way. That's the final step of the implantation. So I think that in order to understand ease of use, we need to go to extreme situations in order to understand that the system is really easy. This is the post-implantation aortogram. She got the title of trivial leak, but actually both here and in echo, we see almost nothing at all. No? So nothing unique to tell about that case. The legs looked okay. This is the echo afterwards. I don't see a lot of leakage, but she got trivial PVL, gradients are good, and she was discharged quickly after. And I think that this case really presents the feasibility of performing a safe Navitor in a very challenging anatomy. Thank you so much.
I have a question, Danny, about the why. I've seen that you have been almost doing a wireless procedure. Is it your common practice to pull the wire out, or it was because of this?
I think that with the push through the aortic valve, the wire was pulled a bit. I imagine, I don't really recall the steps, but it was not my practice because also in the beginning of the procedure, the wire was a bit pulled out. At the end of the procedure, obviously, we all pull out the wire a bit. But here I imagine that while I was pushing, it was pulled out.
I mean, this is a really good case. You were saved. The tortuosity was extreme, but there wasn't very much calcification, and that really made a big difference, both in the iliofemorals and in the aorta and in the arch. So when you pushed the device, it tended to straighten a little bit, which really helped a lot. Another trick that a lot of people use is they take the contralateral pigtail and they put a Lunderquist in it, so you have two stiff wires. And that straightens it much more and makes it even easier. But it's impressive how deliverable this device is in that kind of extreme anatomy. I mean, maybe you can get a short frame device to do that, but there aren't too many long frame devices that I think would have gone so easily.
So then, do you ever use a sheath to bridge or to bypass, so to say, the first level of tortuosity in the iliacs?
If while going it felt abnormal, then I would obviously take it out and put a sheath and then use a body wire from the other leg or something like that. That would have been maybe the advantage of using another femoral access, another ideal in this case. But as you saw, sheathless, it's going through as a snake through very crazy anatomies and no issues.
Okay, so we have many other cases. Thank you so much. This was a great presentation. The next case is is a short cut. It's a provocation.
Not an invocation, but a provocation.
Propagation. Propaganda.
Here we go. Okay, so the first cut is the deepest, the influence of hemodynamics on structural deterioration and survival. So what does this mean? You do not get a second chance to perform your first procedure. Your first cut is the deepest. So whether it's SAVR or TAVR, just think about that. We need to give our patients the best chance for a long-term solution to aortic stenosis. And all second procedures carry challenges and consequences, all not as good as the first, for the surgeon, cardiologist, and the patient, whether it's redo surgery, TAVR and TAVR, TAVR and SAVR, more procedures. But hemodynamic strategy is essential. And for us surgeons, we've known for decades now that the variability in our design and the leaflet preparation and preservation, et cetera, affects structural failure, need for reintervention, survival, and patient prosthesis mismatch has been the enemy for us for decades. And now we talk about TAVR and SAVR. Is there a need to enlarge the root? Is the valve fracturable? What about the leaflet dynamics and leaflet management? 45 years ago this year, PPM was described by a cardiologist who proposed that maybe we're putting too small of valves in our patients and we would have consequences. And in fact, we have a lot of data in the surgical literature that some of the most impactful effects on failure and need for reoperation, here's a 12,500 perimount valves. The most significant influence on need to reintervention is high gradient at procedure and at follow-up. And it correlates very specifically with the degree of postoperative gradient. We even have a registry now with over 60,000 patients in it looking at PPM in surgical patients. Oops, sorry. And there's an 8% increase in mortality with moderate and 32% with severe PPM in follow-up. Any degree of PPM affects survival and increased long-term readmission rates for heart failure. And now moving into TAVR, our Australian colleagues looked at SAVR and TAVR and looked at normal hemodynamics, mildly, moderately, and severely impaired, and found that in their survey, about 25% of their patients had significant PPM. And this did affect their survival. And in fact, patients with severe PPM had a serious 5-year mortality rate. And in fact, moderate or severe impaired valvular hemodynamics in 5 years was 45% and 57% in this population of 6,000 patients evaluated. And of course, Howie Herman's evaluation of the effect on mortality for TAVR, it's pretty disappointing, I think, when we all saw these numbers that over a third of our patients qualified for patient prosthesis mismatch in TAVR, and that had effect on mortality at 1 year, and this was predominantly in valve influence and small valve sizes. A huge meta-analysis, 23 studies looking at 90,000 patients who had TAVR, and you can see here 19,000 versus 62,000 patients with PPM. The most significant influence on mortality was PPM and severe in nature. Well, we've been moving into some of our randomized trials. Here's from the TAVI trial. If you look at surgical patients and TAVR patients with PPM or without PPM, at 1 year, an 8% difference in mortality. And now we're finally accumulating lots of data looking at the differences between the prostheses, the effects on size and annulus, and the effect on valve type. In fact, clearly small annulus has a significant effect on durability in these patients. And also valve type. Balloon expandable and self-expandable valves in the large meta-analysis here showed inferior durability related to compared to self-expanding valves. And I think one of the most interesting papers last year presented at JACC by Mike Reardon was the correlation with SVD on mortality in surgery, TAVR, and also in combined patients. Well, looking over the last few years, I think it's been interesting that the self-expanding valves have performed better than surgery in every trial that's been done and at every point along the follow-up, all the way out to 5 years. And both self-expanding valve has performed better than balloon expandable valve, now out to 5 years in choice and several other analyses. And earlier today, Raj Makarp presented the 5-year data looking at Portico versus commercially available valve, and it showed similar hemodynamics to Evolut, which has shown the best hemodynamics we've seen so far in long-term follow-up in randomized trials, going out to 5 years, and better hemodynamics than SAPIEN 3 out to 5 years. And now that we have the Navitor valve, and albeit only 1 year, the valve hemodynamics at 1 year are really spectacular and very similar to what we saw with first-generation Portico. Much has been made on small gradients. Well, what's the difference? It's only 3 millimeters of difference. This is from the TAVI trial. Although there's a small difference between TAVR and SAVR, if you look at the patients who have high mean gradients at follow-up or small EOAs, they are clearly in the surgical group versus the TAVR group. And looking at small annulus, 23 SAPIEN versus Evolut 26, although the differences are only 6 millimeters in small annuli, if you look at the percent of those patients that have small annulus at 1 year or with greater than 20 millimeters of mercury gradient, there's a 5-fold increase in the balloon expandable group. So regarding surgical valve replacement durability, there's substantial evidence that the elevated Doppler gradients correlate with PPM, leading to structural degeneration and mortality. It's not really much of a controversy. Similarly, there's a substantial and credible evidence elevated transcatheter AVR Doppler gradients correlate with PPM and structural deterioration and its consequences, survival. It's unclear why it's still controversial to me in terms of TAVR. But self-expanding valves seem to have better hemodynamics than balloon expanding valves, which is likely will portend better SVD rates and survival. So do gradients matter? Of course they do. So the first cut is the deepest. We know it's a classic hit, generational. Fontana and Benoni and now Marty probably know that was Cat Stevens who wrote that song, but a half a generation behind us, it was Rod Stewart, right, Francesco? That's who you know. And then, of course, Sheryl Crow, Danny, Dr. Patterson, Dr. DeMarco. That's probably what you think. But I would advocate this should be the anthem of the heart team. The first cut is the deepest. So don't trade established and proven benefits for theoretical events which have very low rates of occurrence. Remember, the first cut truly is the deepest. Thank you.
Director's cut. You know, like coming from Hollywood can only be.
I can't say anything negative about Cat Stevens. So.
Which means basically
It was my college concert
hemodynamics.
days. Yeah, but it's complicated because people used to say that as a surrogate for hemodynamics was whether or not it was intraannular or supraannular. That's wrong. People used to say that as a surrogate for hemodynamics, if it's a short frame versus a long frame, that's also wrong. So it's much more complicated. It's the frame length, it's the shape, it's the leaflet shape, it's a whole variety of things. So I don't think you can generalize so easy into genre subtypes. And then there's the issue, and I'm not quite sure about this. We'll know more with the SMART trial about echo hemodynamics under all circumstances. Remember, the Bernoulli equation was really validated in states of stenosis, not in states of normal flow. So when you're dealing with long tubes that have a lot of turbulence, it has a leveling effect on ultimately looking at gradients and changes. So it's more complicated than I can begin to articulate, but it's just not so simple to put everything in, a corner or in a box. You've got to look at each device individually. And I'll give you some examples. Presented at this meeting will be the DuraValve, the DuraVR. So this is a monoleaflet design, which is a short frame balloon expandable device that has hemodynamics at least as good, probably better than the Evolut. They've done now 19 patients, and we've done careful echoes, and I'm convinced. Right now, to me, the best hemodynamic valve that we've used is the JenaValve. Short frame, self-expanding device, where we've seen in relatively small devices, valve areas of close to 2.5. So I just don't think you can generalize so easily, and you've got to look at each one of these devices individually. What's striking to me about Portico is that with an intra-annular device and with a frame that has very open cells with good coronary access and with good deliverability, you can have such good intra-annular gradients. So I think that's impressive, and I think that that may become important as we make comparisons over the long term.
The data from the Portico RCT, I mean, the comparison with the one from Rush, they're very convincing. What do you want to say?
I think that's true, Marty, but we need to separate the idea of design. Which, yeah, you're right. The next perfect hemodynamic valve may be something that's balloon expandable. It could be something we haven't considered. But fundamentally, with gradients, and every study we've ever done, and even now with TAVR, elevated gradients are not good. And yeah,
They're not good.
And you know, we can go on about pressure recovery and all kinds of measurement at rest versus activity, or versus in the office versus on the table. But at the end of the day, what we want is the lowest gradient possible, and that seems to be consistent in giving us a longer lasting valve, whether it be surgical or TAVR, those four. And if you don't have PPM, survival is benefit too, right?
Agree, completely agree.
Okay, good.
I was
so
worried.
I
He's not gonna
just
agree
want
with
to
me.
say something about Greg. You can sit down. You know, Greg is always ahead of us. Tell you why. Marty, yesterday was Innovators Day, and we've been discussing if you have money. I think some of you were in the audience. We were discussing where to put your money in the future between aortic, mitral, and tricuspid. And the consensus was to invest in a pizzeria. He did it. He did it.
Invest in an Italian restaurant in New York City.
All right.
But remember that the 5 years follow-up to the Portico 1 was presented an hour ago.
Yes, exactly.
So the SVD at 5 years was 0.
Zero, absolutely. That is a single arm. The Portico one is a registry. There has been also, just before this session, the RCT from Raj Makar also showing a great difference in valve areas and gradients in the Portico compared to other commercial valves overall. So, very interesting data. Obviously, they need to be assessed a bit more carefully, but, you know, be careful. Exactly. Being careful. You know, the best pizza is a quattro stagioni. You put a bit of everything, so everybody is happy. Now, let's go with the next presentation. Yes, this is you. It's exactly you, Federico De Marco, who is going to speak about something which is off-label. I need to say it again. I don't know why, because you didn't find the third leaflet.
So let's just jump directly into the case. It's a 71-year-old female, hypertensive with dyslipidemia. Her past medical history has a known bicuspid aortic valve under periodic clinical and echo follow-up. In 2020, she has had an ischemic stroke, which was treated with thrombolytic therapy, and this was probably due to a paroxysmal AF, which was diagnosed through an ILR after this episode, and after which she obviously started NOAC therapy. This is her echo. There is severe aortic stenosis with 42 mean gradient. We had a discussion, and because of the quite recent stroke, the patient was deemed at high risk for surgery. She was just above 70, and so the heart team discussion addressed the patient for TAVI. This is her CT anatomy. You see the calcifications are not extreme, but it's definitely a two-leaflet valve. We have one large coronary leaflet and one minor non-coronary leaflets, with most of the calcification sitting on the free margin of the leaflets. We also have some dense calcium, and the perimeter-derived diameter is 23.1, which is just at the border between a 25 and a 27 millimeter valve. The area is 413 square millimeter, and the eccentricity is not super severe, with a minor axis of 21 and a larger axis just above 25 millimeter. We decided to treat this patient with a 25 millimeter Navitor valve. We do not like the strategy of excessive oversizing in bicuspid, and this is motivated by the use of different platforms. So we consistently with our strategy, we decided to use a 25 millimeter valve. This is the baseline angiogram. You see some calcification at the level of the aortic valve. We did a pre-dilatation with a 23 millimeter semi-compliant balloon, obviously looking perpendicular to the opening, so in order to see the calcification displacement when the balloon was inflated. Then we advanced the Navitor 25 millimeter device, which was implanted really with a super slow release in order for the device to find its place and to avoid, excessive movement of the device. After a while, we started some controlled pacing, just above 100 BPM. The device probably, was ending up a little bit too low, so we pushed a little bit on the guide wire in order to optimize the positioning. Here, obviously, the device appears quite low towards the left sinus, but that's probably also due to the fact that this is bicuspid valve and the calcifications are quite higher. Anyway, this is the final position, just a couple of millimeters below the virtual basal ring. We quite like this final position, and after waiting for a couple of minutes for the nitinol to heat properly and for the device to sit in the anatomy, we went to the final release of the 3 retaining tabs from the device. This is the final angiographic outcome, which is really good, and also in a sort of a perpendicular view, we do not see any constraint of the valve, any asymmetry of expansion, so we decided not to post-dilate the patient. This is the follow-up echo, surface echo, obviously, with hardly any visible PV leak. And the gradient also was single-digit, and the outcome particularly good. I have just some discussion points. We decided to use the Navitor device in a young patient. TAVI was favored, obviously, because of the recent stroke, and this is a type 0 bicuspid, which, again, is off-label, but I think that the Navitor device has really an excellent conformability and also has very good sealing, also in eccentric anatomies.
Good job. The first question is, I want to ask you first question. Would you do this with the Portico? Probably not. Navitor is really an advantage here. It's been a step forward.
Absolutely. I think the addition, of a nice sealing cuff, which is really effective in preventing PVL, has kind of, paved the way towards dealing more challenging anatomies with this platform.
To be honest, I'm also a pretty, I use the platform often, and I start now to think about this platform into bicuspid. We have been using different platforms in the past. It's opening a new chapter here. It's still a debated arena. What is the best TAVR platform for bicuspid? I know that. Marty, you are very sensible in this topic, correct? There are many different.
No, I think that people, rush to do bicuspids, and I don't know that that's the right thing. Surgery is still pretty good in some of these patients, especially if they have aortopathy or if they have, really extreme leaflet calcification with a calcified raphe. So if you're going to start, I think type 0s are a good place to start. And this was fairly symmetric. And the calcification at the annular level was not that great, with almost nothing extending into the outflow tract. And even the calcification of the leaflets was not that great. So I think this is a really good one to start with. And you got a great result. So, I applaud you. So I think it's a well-selected bicuspid and a good case to start with, yeah.
Bicuspid, I just want to remind you, probably 2003, Milano, our first case together.
That's right. I'd like to remind you that the first case ever done in 2002 by Alain Cribier was also a bicuspid. So yes.
So you see, that is interesting because we are still, it's off-label, but really we didn't care too much at the beginning.
Yeah.
I think is 1 point for versatility again. I mean, it becomes even more versatile, this platform. I think I forgot about the hemodynamics. Any comment? Are you surprised by seeing bicuspid in this?
I mean, why would it not work? Because this is a easier bicuspid version than a typical type 1 that has a nasty raphe and all this kind of stuff. But I think you brought out a very important point that if you are in between sizes, or even if you would be in a full 27, still we don't know whether or not what people sometimes refer to as downsizing, which I would say it's a true sizing because you size the valve to the anatomy in the bicuspid, especially type 0. The supraannular sizing concepts, there are lots of stuff to start discussion about, and I think there's not enough expertise yet with the Navitor platform because it's technically not allowed, right? So that we cannot really start the discussion on the scientific ground, but with other platforms, it's the usual discussion that would start right away now. How do you do the sizing? Any place for balloon sizing and this kind of stuff?
I agree with you. I mean, there is a lot of gray in bicuspids. You can have some extreme levels of calcifications, which we see more in bicuspid anatomies as compared probably to tricuspid. And again, this was not not a challenging case in terms of calcification, but still you can see some unexpected behavior of the calcium in bicuspids.
Thank you very much. We need to move forward. We are now, I think it is a escalation of complexity. This is called Russian dolls. I can only tell you what is about it.
So the responsibility of the title is of Francesco anyway, so obviously. So this is a case, this is my case, my conflict of interest is an 80 years old male with the usual comorbidities. He was treating just some month before for an PCI, multivessel PCI. He was operated in 2004 with a Bental procedure with a perimount 23 due to severe aortic regurgitation and ascending aortic aneurysm. This is the valve. You know, it's a 23 paramount. Inner diameter through ID is a 21. At the end of the year, he had the worsening of shortness, and I was hospitalized. This is the echocardiographic assessment. There's a severe prosthetic degeneration with mean gradient 35 millimeters mercury and severe regurgitation. So the indication was valve in valve. This is the CT procedural evaluation. You can see that the annulus size is compatible with the valve size, the prosthesis size. The VTC is short, but the height of the coronary artery are quite high, so no problem about the coronary occlusion because 20 millimeters in the height of the both coronary. This is the angio, severe regurgitation. Following our experience, started in the 2015, we proceeded with the valve-in-valve procedure with Portico, 23 millimeters. Because we had, despite the fact that this is a bailout procedure, but we had a large experience on that. So we started with the procedure. This is the initial position. And unfortunately, this is the final position. The valve slided down a little bit, but now we have the crown deep. So it's what we expect as a result, but the pressure not so bad. The echo shows mild regurgitation. So at the beginning, we accepted this with this result, and we decided to follow up the patient. but the follow-up was not so nice. You had the CRD implantation, that again acute admission for pulmonary edema, and so we have to review the patient. This is the angio you will see. Probably the valve slide down a little bit more because now we have 1 crown and a half in the ventricle. The regurgitation is important. The patient didn't tolerate it, so we proceeded with valve in valve. We snare to avoid to push down again the valve. Go inside, and this time we decided to use Navitor, which was available. No problem to cross the valve. And we proceed, pay attention with the 8 to the second implantation. You can see this is the release in pre-cusp view and cusp overlap view. This is the final result with very good pressure this time, and we check the coronary access with despite the fact we have two valve. We have no problem to go deep in coronary artery due to the large stem cells. It is very important. So the take-home message is the problem in valve procedure is gradient and coronary access and risk of coronary occlusion. I think when the Port and Navitor now are very interesting valve for valve-in-valve procedure because of the light metallic structure. It's now non-flared valve, the good that leads to have a very good hemodynamics, and even in small annulus, large stem cell give us easy coronary access, with the wide possibility of TAVI procedure, and probably Navitor with higher radial force compared to the Portico is we may work even better. Thank you so much.
Thank you, Francesco. Unfortunately, we are over time already, but we have time for some discussion. I think it's a proof of concept, correct? So it was not really a degenerated disease, genetic disease, but it's a proof of concept that you can do multiple TAVR in TAVR and think about the future when we talk to our patients. What do you think, Jorg, to you maybe? Because now
so first of all, I have to say it. The first valve, the surgical one, although it was only a 23, which is rather on the small side for a male, lasted 17 years. So it's something that is very reassuring that it can be, coming back to the concept, the first cut is the deepest. It's a good platform to put in any transcatheter valve later on. It's much easier than doing a TAVR and TAVR. Not saying it's not possible, but obviously less hassle. And of the valve and TAVR that you had here, yes, of course it is proving that you can put several layers, but here we have to be fair. The first one slipped in the ventricle, which also kind of, the risk plane, the neoskirt also went down, right? So we didn't have two true TAVR and TAVR devices. Also, I'm not saying that it wouldn't work with the Navitor because it's less stuff in front of the coronary, so the neoskirt is lower than in some competitor valves, but here we have to be fair. There was no real risk of coronary obstruction.
Well, anyway, the Benta procedure showed the coronary implant was very high. So I don't think that some millimeters in higher position will change anyway. But it's to show that the access, even with two frame cells, is very easy.
Very important. There are no surgeons in the room. I always say when you do Benta, put the coronaries high. So that, I always say that in surgical meetings. You should go and tell your surgeons.
But not only for the cardiologists, also that you don't get a kink, right?
Yeah, sure. So, no, it was
I would like to summarize that in this situation, the height of the skirt matters. So, for the future intervention.
So since we are in the summaries, Marty, you want to summarize? No. So, I mean, we have been, I summarize just shortly what we have said, and I give you the last word. I think hemodynamics, first cut, blah, 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 okay? Hemodynamics, we are convinced we have a good platform for hemodynamics. We have been seeing that really versatility in different complex anatomies, including even the bicuspid valve. We have been now testing the concept of revalvability, whatever, and coronary access. So overall, we are in a good direction. So what do you think, Martin?
No, I'm thrilled. I think having new TAVR platforms are going to make a difference. So I think that we're delighted to see that Portico Navitor is going to be, in the United States with an expanded indication that would allow us to be able to treat more patients. We still have more work to do, but I think it's a great entry into the portfolio of devices we have. It's got some fairly unique characteristics and a lot of attributes, and I think that the structuralists are going to really take advantage of those things. I would argue that the more data you accumulate, the better, because the predicate devices have a lot of data, and seeing the 5-year data for me makes me feel more comfortable, so that's important. I would like to see not just a single case, but I think you should be doing registries with carefully selected bicuspids, and you should be doing valve-in-valve, and you should be trying to extend the indications in such a way that you can better advise the structuralist based upon experience and evidence rather than based upon anecdote. So I think that's one of the things that I would strongly encourage. But this is a great start, and I learned a lot in this 1 hour, and we did a good job together to define the ideal TAVI platform.
Thank you so much, and thank you, everybody. Thanks, Abbott.